This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Heinz-Josef Lenz, Associate Director for Clinical Research and co-leader of the Gastrointestinal Cancers Program at the USC Norris Comprehensive Cancer Center. Dr. Lenz is Professor of Medicine and Preventive Medicine, Section Head of GI Oncology in the Division of Medical Oncology, and co-director of the Colorectal Center at the Keck School of Medicine at the University of Southern California. Welcome back, Dr. Lenz.
I'm happy to be back.
For the newly diagnosed advanced or metastatic colorectal cancer patient, is there an order of how you would treat them? Is there a standard of care? What can the newly diagnosed patient expect to start out? What would be their first clinical approach?
In the newly diagnosed, we have clearly options of treatment. We have 2 chemotherapy cocktails, the 5FU and Irino combinations, which is called FOLFIRI, and the 5FU oxaliplatin combination, which is called FOLFOX. And we have 2 antibodies, one targeting the tumor vasculature, that's its bevacizumab or Avastin, or targeting the EGF receptor, cetuximab or panitumumab. Now, depending where you go in the world, you may get FOLFOX bevacizumab, you get FOLFIRI bevacizumab, you get FOLFIRI cetuximab or FOLFOX cetuximab. What's the right thing? It shouldn't be not driven by your habit. It should be driven by molecular diagnostic, where the likelihood of sensitivity is better for this particular combination. So what happens right now is that its extensive mutational screen is done, that we at least know is an EGF receptor better or a bevacizumab better.
Dr. Lenz, that will happen at a cancer center such as yours at USC. What happens in the community? Are these, like with lung cancer, we know that you have to do a molecular profiling before you treat? Have we come that far with colon cancer?
I think it started that patients are treated almost routinely for KRAS testing, but this meeting made very clear, KRAS is not enough. It's the tip of the iceberg, but not the iceberg. We need to do more codon mutations in the KRAS gene. We have to include NRAS and more. And we will increase the efficacy and the selection success.
If a patient who's diagnosed isn't offered this testing or doesn't even know if the doctor did the testing, what is the message we need to tell patients? What do they need to own in their part of the relationship on behalf of their cancer care for colon cancer?
Yeah, so I think there is a significant deficit of information, and I think it's very complex. And the physician community as well as the patient community is sometimes overwhelmed with the speed of developing technology and the laboratories offering that. And it can be very confusing. I think we are now doing a program with Cancer Commons in order to really streamline this process, to really have a website developed identifying what mutation you should do, where you can do it. You can print out what you need to do and go with a printer to your doctor and saying, can we do this? And then with that, I think it makes it easier to discuss treatment options. I think there will be a learning process in this, but of course the goal of that not only is teaching the physicians and the patients, but eventually collect an incredible data set of patients with extensive molecular profiling and capture the outcome. I think this will put the patient back in the driver's seat and control of their own treatment. I think it's absolutely critical that the patients should be part of the strategy and the treatment decisions. Only then you get commitment and dedication to do the best possible.
Thank you, Dr. Lenz, Associate Director for Clinical Research and co-leader of the Gastrointestinal Cancers Program at the USC Norris Comprehensive Cancer Center, Professor of Medicine and Preventive Medicine, Section Head of GI Oncology in the Division of Medical Oncology, and co-director of the Colorectal Center of the Keck School of Medicine at the University of Southern California.
Thank you very much for having me.
Thank you for being back.